Right. Always nice to see you. So thank you very much for joining us. So,
Thanks for having
um,
me.
no, it's a pleasure. It's been a while, actually. It's been a while. So yeah,
Mm,
good to be back. Right. So we're live here in the room in Click Meeting, which is
mhm,
nice to see. Lots of people with
mhm,
us, and we are live on Facebook.
mm.
So if you haven't seen Palak before, you have no idea what you've been missing. So we'll get onto that shortly. But just to remind you that what we're doing today is we are going over general medical information. We're certainly not giving specific medical advice. And what we hope to do with our answers, I say our answers, with Palak's answers, is really help you in your next conversation with your clinicians to empower you with information and knowledge so that you can ask the best questions that you can and hopefully take you forward in your PBC journey. So, with that all said, hello to you, sir. How are you?
I'm good. I'm good. It's lovely to be back. It has been a little while since I've done one of these, so I'm very grateful that you've invited me back.
No, it's always a pleasure. It's always a pleasure. So, right, we've got questions. So, shall we get started, shall we?
Mm,
Okay, so we've got a few questions that all came together, and they
mhm,
all refer to Dr. Jones' book, or
mm.
Professor Jones' book, or, well, Dave's book. So, no idea if you've read it or not, but
I
here we
haven't read
go.
it. I haven't read it. Yes, I
Right,
haven't read it, I'm afraid, but yeah.
okay. So, we've got somebody whose AMA was positive, but it is now negative.
Hmm.
And they're curious as to why. Now, they
Hmm.
don't, it doesn't say anything about their ALP or anything like that. So, it just talks
Mm,
about their AMA there, too. So the first question is, in terms of AMA being positive, then negative.
mhm,
Secondly, they have markers for ANA, but again,
mhm,
they've read that the pattern and stain is more
mhm,
important than the actual number.
mhm.
Um, so can you talk about kind of the autoimmune markers, the antibodies, and all of those kind of things? And maybe just give people a general picture
Yeah,
of what
sure, absolutely.
ANA is, that kind of thing.
Yeah, absolutely.
Thank you.
So, what's being referred to here are antibodies. These are proteins that are made by the body, which normally would fight things like infection and foreign material. And we recognize that in people with PBC, there are certain antibodies which help diagnose the condition, but rather than being directed towards an infectious process, these antibodies signify that they may be, and may is the key question, be some immune attack against the bile ducts, the tubes that drain bile from the liver, the very small ones that you can't see on scans, but the ones at a microscopic level. And when we see these antibodies in people together with liver blood tests that are abnormal or symptoms of PBC, then we would make that diagnosis of PBC. It's important to recognize, though, that not everybody with these antibodies has PBC or will develop PBC. There have been lots of studies looking at people who have antibodies of what we call AMA, so anti mitochondrial antibodies. And there was a large study in France, which I want to call out in particular, which was published a few years ago. And what it looked at was several, thousand people who had positivity for AMA without any evidence of PBC. And roughly for every 100,000 people they looked at who had who were in the population, about 16 of those had AMA positivity. So without PBC, about 100,000 people in the population of that group, 16 of them, a small number, will have AMA positivity. Okay. Now, in that particular group, over the course of time, um, you say let's take a 5 years as an example. 16% of that 16 per 100,000 individuals will go on to get PBC. So it's a very small number. But the important thing to notice is that some of them, even though it's a small number, it's not going to be small to you if you're one of those individuals who gets the condition. So what we tend to advise is that in people who have AMA positivity with normal liver bloods, I ask the questions: do you have any other autoimmune conditions, such as gluten sensitivity, celiac disease, rheumatoid arthritis? Do you have what we call Sjogren syndrome, which is lots of dry eyes, dry mouth? these things are more common in people with PBC. So if you've got those antibodies, AMA, I would be more inclined to follow you up in my program rather than referring you back to your GP. And all I may do is have a chat once every couple of years and check your liver bloods and be sure that you don't have any new symptoms of concern. If, however, you do not have that personal history of other autoimmune diseases and you have no family history of PBC or any other autoimmune diseases, then in those situations I would say I'm happy for your GP to follow you up and check your bloods every couple of years. But if at any point you're concerned or your GP is concerned, just let me know. So that's what I would that's what I would do. The other antibody that was referred to in the question was anti-nuclear antibodies, or ANA. Now they actually are a lot more common sort of in people with PBC. Um, Now I disagree that it's only the staining pattern. I do believe that the quantity, the titer, which means how many times do you have to dilute that blood sample to get rid of the antibody, I think both are important, and both are important according to what age group you are. So, in a young person, say a child or a teenager or a young adult, even low levels, low titer ANAs are significant. So if somebody is age 14, 15 years old, and I think the youngest person that's ever been diagnosed with PBC is a girl from, well, no longer a girl, but sort of a person from Canada that was written up by our colleagues, Andrew Mason and co in Edmonton. That was 15, this person was 15 years old, and even a titer of what we would say 1 in 10, which is a low, what we would consider a low titer, would be, it would be significant. But in somebody who's, say, somebody in their 40s, like myself, or somebody who's of older age, that sort of titer would just be ignored because that is common. We develop these antibodies as we grow older, anti-nuclear antibodies as we grow older, as a sign that we've been exposed to different things in our in our lives, other infections, other medications. And ANA, anti-nuclear antibodies, are not so disease-specific like anti-mitochondrial antibodies are. We see that in a variety of conditions. Even in people with sudden onset infections, we can see ANA rising and then falling, rising and then falling. So I have less weight on ANA as a general sort of antibody compared to anti-mitochondrial antibodies. But that's just like a brief overview. There are some PBC specific anti-nuclear antibodies that we can detect. It's very much what we would consider fine print, in the sense that it's important for your doctors to recognize them, and it's important for them to investigate if they do find anti-nuclear antibodies. But I wouldn't expect everybody to know about them.
Okay, perfect. Thank you. Next question. Fasting, and I'm going to add intermittent fasting, and then I'm going to add losing weight. Do any of these have an impact on ALP?
It depends on what the cause of the ALP, elevation is. If somebody has a elevated ALP, we have not found any evidence to show that in PBC, elevated ALP is positively or negatively impacted by intermittent fasting. But in some people who have an increased BMI, so they have increased body weight, and their ALP may be impacted upon because of diet, because of other what we would consider metabolic risk factors, such as diabetes or fat on the liver, then intermittent fasting won't necessarily have a direct effect on liver ALP on a day-to-day basis, but long term, the health benefits of intermittent fasting and the associated effect on metabolic profile would certainly sort of lead to most liver enzymes coming down. But that's not PBC specific. That's just a general health observation.
Okay, perfect. Thank you. We've had a couple of questions with regard to painkillers. So, we're asked about the kind of ibuprofens, and Tylenol, which is paracetamol,
Mm.
and also about anything you can take for colds, fevers, and COVID
Mhm.
with that. So,
Yeah.
any thoughts on painkillers and medications, please?
So anti-inflammatories such as ibuprofen, diclofenac, indomethacin, Nurofen, we generally say avoid if you can. I mean, there are some health conditions where their benefit does outweigh the risk, but there is a risk of causing liver inflammation, of things such as stomach ulcers, and of course in kidney problems, and that's irrespective of whether you have PBC or not. So even in people without PBC or without known liver disease, we say minimize the amount that you need to take, keep it short term, keep it infrequent, and if you're certainly needing it for more than a couple of days, then don't do so without the explicit, advice and permission of your hospital physician or GP. Um, and other painkillers that we would permit, however, is we would certainly permit paracetamol, provided people don't go over the recommended daily allowance, which is 4 grams a day. And I don't know what dosages paracetamol slash Tylenol, sorry, not acetaminophen, comes in in North America, but certainly in the UK, paracetamol is comes in 500 milligram doses, and we would normally say 2 tablets taken every 6 hours, or no more than 4 grams a day, so no more than 8 tablets a day, provided you're within that limit. It is very, very, very unlikely to cause any problems at all. The reason I'm not saying it will never cause a problem is because some people who have got lower body weight, so below 50 kilograms, we would normally say just take 1 paracetamol every 4 to 6 hours with a maximum of 4 tablets at that dosage in a 24-hour period. Codeine and morphine and tramadol, these slightly harder painkillers, which are sometimes offered particularly for those people undergoing surgery or with long-term health conditions that lead to pain. Again, only with the permission of your consultant and or your GP would you take them. It is not harmful to the liver, but in people with very advanced liver diseases, they can tend to accumulate these medications, and side effects may be more pronounced, such as nausea, itching, vomiting, drowsiness, constipation. So in summary, avoid things like anti-inflammatories. Paracetamol is fine. Tramadol, codeine, morphine are fine, but in advanced liver disease, they may build up and may have tolerability problems. In COVID, when we see people with COVID, we do advise people taking paracetamol to keep their temperature down. When Colette was running the organization, sort of with you, Robert, then we did a small session like this on COVID for people with PBC. And I'll just refresh that advice for anybody who's interested. And thankfully, COVID is a lot less severe now than it was in the peak. But if you have COVID infection, our general advice is do take plenty of fluid, do take paracetamol, and if you need to take ibuprofen for body aches and fever, take it in moderation. If you buy a thermometer and if your temperature is more than 37.8, 38 degrees on day 4 or 5, or if you feel that you have any chest pain or confusional states, and in particular, if you have a saturation monitor, which I also encourage people to buy, and that saturation monitor is showing saturations below 94%, those are the 3 trigger points, where we would advise you seeking medical advice. So persistent fever after day 4 or 5. If your saturations go below 94 at any point, and if you have anything such as chest pain, confusional states, dizziness, then at that point you should seek medical attention. So, but paracetamol is fine to take if you have COVID.
Okay, perfect. Thank you. That's helpful. So you mentioned the I word. So let's go there. So a couple of questions about itch, if I may. So somebody is they're currently abroad. So they've got kind of different water or different hardness of water, different shower gels providers, etc. But they're experiencing itch and it's a brand new thing. So their question is, does PBC itch appear suddenly? Or do we think that it could be down to just the different toiletries and that kind of thing that's causing the itch? Any thought?
So in my experience, when we see itch related to PBC, it's not something that comes on instantly, suddenly, as you refer to, Robert. We tend to see it as you can't really tell, right, this day I woke up and my PBC itch started. The only exception to that, I would say, is there are certain medications which can unmask PBC itch that we use. But for most people, the itch tends to come on, at least in our observation, at least over a few days, weeks, months, rather than instantaneously. So if you experience sudden onset itch one day, it's more likely to be something else than your PBC related itch. The only exception is in people who take certain medications, such as obeticholic acid, which is a very, very good medication for treating PBC not responding to urso. But about 1 in 3 people who have itching can notice the itch getting a bit worse, which is manageable, and we can talk through that if you want later. But that's the only real time where we see it coming on suddenly.
Okay, perfect. Thank you. That's helpful. Sorry, forgive me. I'm looking away at the screen. So normally my questions are up here,
That's
but
okay.
today my questions are down here. So I'm staring at my questions here.
It's okay.
Question. Reflux and
Mhm.
PBC. Anything you can offer in terms of, is there a link? Do we know the cause? Do we know the solutions? Any
Mm.
thoughts?
I mean, it's a very good question that we've had a few times before on this call. We don't tend to find any association between reflux and PBC specifically. Lots of people who have any form of chronic condition, PBC, inflammatory bowel disease, arthritis, do experience more reflux than people without those conditions. And we think that's because when you have a chronic condition, your body releases certain hormones and inflammatory markers which make your stomach and your gastrointestinal tract more predisposed to reflux. And some people, for instance, who are training for things like marathons and sporting events, who have reduced sleep overnight because they're waking up early for training, their body produces similar stress hormones and they also experience a lot more reflux, but for different reasons. So we don't think, at least based on current observations, that it's PBC linked. In terms of what you can take for it, so over the counter medicines such as Gaviscon or Peptac are useful if you get it episodically. And if you have it on a regular basis, then you can buy now over the counter esomeprazole, which is an antacid tablet. It used to be available on prescription only, and certainly other medications in its class are only available on prescription. But esomeprazole is a very effective medication at 20 milligrams per day to help with reflux. And if you need it, if that doesn't work, then we would certainly advise you to see your GP. Esomeprazole, we would say, takes a couple of days to work. So we wouldn't expect it to work instantly. But Gaviscon works pretty quickly if you have reflux.
Okay, perfect. Thank you. Low ferritin, is that a PBC thing?
It's not a PBC thing, but low ferritin. So ferritin it's a marker of your iron levels in circulation, and if your ferritin is low, we get concerned that you might be iron deficient. Um, iron deficiency is normal, but should not be left untreated if it's causing symptoms in people, particularly women who are below the age of 50, 55 years old, who are still actively menstruating. So if you have a low ferritin and you're still having your periods, that is normal, common, and very if it's causing you symptoms, should certainly be treated. If you're a man or at any age, or if you have ferritin values that are low and your periods have stopped, then we would certainly encourage investigation to see if you are not having enough iron in your diet, or if you're having enough iron but you're not absorbing it, or if you're losing iron, for example, through a polyp or an ulcer or inflammation in the gut. It is not linked to PBC, but low ferritin can be seen in other conditions that coexist with PBC, such as celiac disease, so gluten
Yeah.
intolerance. It can be seen in in those individuals. In people who've got very, 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 very advanced liver disease to the point where they are on liver transplant lists, for example, they're jaundiced and have markers of advanced disease, they may not necessarily have a low ferritin, but they can also be anemic, for other reasons. So because their body is in a state of quite significant inflammation. So anemia is low hemoglobin. Low ferritin can lead to anemia. So it's important just to be mindful that that I'm talking about two slightly different things. Low ferritin can give you anemia, but anemia can be due to multiple other causes as well.
Yeah. Okay, that's helpful. All right, thank you. Here's a question. If somebody is on a clinical trial
Mhm.
for an itch compound.
Yeah.
And whilst they're on the trial, their ALK phos is still rising.
Hmm.
And it's a pattern as opposed to a one-off.
Yeah.
Given that second line therapies are linked with different itch profiles,
Hmm.
which may then interfere with the itch trial,
Hmm.
what's a good question for this person to ask? What's their next step? What should they be asking? What should they be considering?
So just so I've got it clear, this person is in an so if somebody is in an itch trial,
Yep.
but which means that whilst they're in the trial, they're starting a new second line therapy is prohibited, or if they were to start it, they would have to come out of the itch trial.
Right.
Is
Well,
that right? Or
so that's what I'm asking. I'm
yeah.
presuming that's the
Okay,
case,
okay.
but
Yeah, yeah, yeah.
is that the
So
case?
yeah. So it's important to recognize that there is a lot of emphasis on the timing that we start therapy in people with PBC. So delaying things such as first line therapy, second line therapy is what we are trying to avoid in general. Now, a few days of delay in starting a second line therapy or even a first line therapy will not make that much difference to the long term trajectory of people. And dare I say, a week to 2 weeks will not make a big difference sort of in delay in starting therapy. Now, some people say, well, what is acceptable what is an acceptable delay? We haven't sort of we haven't sort of gone to that much depth in the research field saying that delaying first or second line therapy by 12 weeks is more dangerous than delaying it by 3 weeks. No, we don't have that body of data for second line therapy. The reason I'm going around down that rabbit hole is because when somebody is in an anti-itch trial, um, it is important to be mindful that most of the trials that we do in PBC in this day and age are placebo controlled. So we don't know if you're in an active treatment arm or in a placebo arm, i.e., having
Yeah.
a dummy pill. So if your symptoms are persistent, it doesn't mean that the trial's not working. We just don't know what arm you're in. But equally, if you find that your bloods are going up whilst you're being in that trial, the two questions are to ask are: number one, should I still continue in this trial? And
Yep.
if you are experiencing no benefit to your itch symptoms, and you don't know whether you're receiving placebo or active treatment, and your bloods are going up, ask your physician, should I still stay in this trial? And people can ask me that question. And if the trial is of short duration, and I probably define short anything less than 4 months, I would say, well, depending on the magnitude of abnormality in your liver bloods, and depending on how that trajectory is going, I will say yes or no. I said it's up completely up to you, but my advice is that if your bloods have become slightly more elevated in that direction, I'll say at the moment I'm not too concerned. This is still something that we can bring under control at the end of the trial, and I would mention that particularly if the individual feels that they're benefiting symptomatically from being part of that study. If they say, I've got no benefit in the itch, it's exactly as it was, and my bloods are getting worse, I've been in this trial for 3 months, what shall I do? Then I will say, look, if I'm being very honest, if you're not benefiting from it at all, and I can see your bloods deteriorating, then my advice would be I don't believe that being in this study is helping you in any way, but there may be other agents that we can offer that can help bring your bloods under control and potentially, again, I don't know this person's background, and potentially also help your itch. So that individual may then decide to come out. But if they're having symptomatic benefit and the bloods have risen but are not too bad, then I may encourage them to stay in the study.
Okay, perfect. That's helpful. Thank you. Right, there'll be a few questions coming in about cholesterol.
Mhm.
So, one, can you talk a little about cholesterol and PBC, please?
Yeah.
I have a question in the room which says that somebody needs to start a statin.
Uh-huh.
I have questions about that, but that's a personal thing. Um, which statin is safe, and also is Paxlovid safe to take if you have COVID? I think those are two different questions. So, will
Okay.
we talk about cholesterol first, please?
Yeah. So elevated cholesterol values are common in people who have PBC or any other long-term condition that affects the bile ducts. That is common. and that's because bile is made from cholesterol. Now, elevated cholesterol values in the context of PBC don't always mean the person is at a higher risk of developing heart attacks, strokes, and so on and so forth. What we recognize is that the elevated cholesterol in people with PBC, a large proportion of that consists of a good cholesterol called lipoprotein X. Now, most UK laboratories in general hospitals cannot check for that. Lipoprotein X is very much a research laboratory tool, not something that is present in most labs. So you can't go and ask your consultant or GP, can you check my lipoprotein X levels? It's just not available in routine practice. But most people with PBC who have elevated cholesterol will have elevated values like that. The second thing to say, going back to, is around the risk. What we advise is that if that individual has no other risk factors for cardiovascular or cerebrovascular disease, strokes, such as smoking, such as high blood pressure, such as diabetes, kidney disease, and or a family history of young age onset heart disease, there is no need to start a statin, even if the cholesterol value is high.
Yeah.
And what we do see in people like this is that if in those few people with PBC, thankfully, who end up needing a liver transplant, their cholesterol levels do normalize after they're transplanted. Uh,
Uh-huh.
so,
Okay.
so, so we recognize that it's the PBC. So that's a marker of it. Now, we never transplant people because of high cholesterol, but it's just an observation that we see. Now, of course, some of the immunosuppression that we put people on after they're transplanted can push that cholesterol back up in later life, but that's a different topic. But for most people with PBC, we don't need statins unless they've got other risk factors that would put them at risk of other factors that put them at risk of heart disease or strokes.
Perfect.
Statins. So if you are started on a statin, either because you've got a high cholesterol and you have an increased body weight, or you have diabetes, or you have hypertension, or whatever other risk factor that people think that you have, generally speaking, all are safe in PBC. There are other cholesterol lowering medicines that we might offer you beyond statins in PBC. For example, there's a medication called bezafibrate or fenofibrate, which we use if you're not responding to urso to bring your alkaline phosphatase level down, your liver biochemistry down, but they will also lower your cholesterol. So if we feel as physicians that you are likely to need something to help your alkaline phosphatase come down beyond urso, then we may say, hold off starting a statin just yet, because you may go on to need a fibrate, bezafibrate or fenofibrate instead. And there's no point being on two medications that do a similar thing. Do you want me to take anything, talk about more cholesterol more, or shall I move on to the Paxlovid COVID
Yeah, I
question?
think if we can, so no, I think that's helpful in terms of cholesterol. So in terms of the mechanism, so there's been a lot of talk about the mechanism that statins use to lower the cholesterol and whether or not
Yeah.
that's helpful, and I'd love a view on that. But is that a different mechanism to the fibrates and how they lower cholesterol?
Yeah, sure. So, it's a very
Nice
good
of you
question.
today, Palak.
Yeah, no, that's okay. So this is lipid biology more so than liver biology, but yeah. So cholesterol lower it because they've got this, and the most effective at doing so if you take it at night, just before you go to bed. But there's an enzyme, which has got a very long name, but the short name is HMG CoA, reductase. That's the short name, HMG CoA reductase, and that's the rate limiting step of cholesterol synthesis, and that's how. And not fibrates, statins interrupt that process. That's how they work. So fibrates work differently to statins. So that was a statin mechanism. Fibrates work differently because they stimulate your cells in your body to take up what we call fatty acids, and they convert them to what we call acyl CoA derivatives. And so theirs is very different. That pathway is very different. They're not sort of enzyme inhibitors. They are very much and promote oxidation of fatty acids, whereas statins inhibit the actual production of cholesterol. So they work slightly differently. There are some few people who we put both on statin and a fibrate, but they're very much the exception rather than the rule. Normally we pick one rather than both agents.
Okay, that's helpful. Thank you.
Yeah.
Okay, next question. Now, this might be slightly awkward for you to answer, but it might not. So, as you run an ODN,
Hmm.
so we won't name names, but somebody is over the threshold for being referred to an ODN.
Yeah, the bloods you mean are over the threshold.
Yep.
Yeah,
So
yeah,
they're,
okay.
they're alk phos and all that kind of thing. They're
Yeah,
not
yeah.
responding to URSO.
Hmm.
Consultant has referred to the ODN,
Hmm.
but is not heard back.
Okay.
So, what can the patient and or consultant do to make sure that this person gets second line therapy as quickly as possible?
Oh yeah, that's an important thing. So, I mean, sadly, in the modern NHS, it happens relatively often, and I wouldn't say often. I mean, at least once a month, we have an email to our ODN saying we referred this person to you, and we have not heard back, and that is very much a victim um, of modern administration and NHS pressures and the impact on our secretaries and co. That is not an excuse; it's purely an explanation and some reassurance. I don't know if this person's to our ODN or others, but it sadly happens in most ODNs and MDTs now. It is not acceptable. There is no right or wrong way to deal with this problem, but my advice is that whenever somebody is referred to us, then we would say, if you haven't heard back regarding an MDT outcome within 4 weeks, then reach out again. That's the first thing. So if I'm referred by a colleague of mine, so I work in Birmingham, if I referred somebody from Coventry, and that person, and I will say, okay, that's fine, provided we have all the information to discuss in our ODN. We would say, if you haven't heard back in 4 weeks, let me know. And for those people who don't know what an ODN is, at the moment, people who have PBC, vast majority will respond to ursodeoxycholic acid. But for the group of people who don't respond to ursodeoxycholic acid, we would suggest that they take a second line therapy. To get that second line therapy, they would have to be referred to a larger center, what we call a hub center, that is that is the core of an operational delivery network, which is what the terminology ODN that Robert was referring to, i.e., a center that has access to give you a second line therapy. When your consultant refers you to the ODN, they should be very clear with you and say, I'm referring you to the Birmingham ODN or to the Newcastle ODN or to the Cambridge ODN or the Oxford ODN. And the lead physician is Dr. Trivedi or Dr. Culver in Oxford or Dr. Mells in Cambridge, Dr. Jones or Dr. Dyson in Newcastle.
Yeah.
And they can also say, if you have not heard in 4 weeks, either let me know or you can make contact through the switchboard of that hospital secretary. And I have and I give over and they should be able to do that, saying I've been referred but I haven't heard back. The ODNs are only conducted in most hospitals once a month. Some places it may be less frequent than that, but that's important to convey back to the referrer and
Yeah.
say our next ODN is going to be this month or next month on this particular date. And sadly, with things such as industrial action, biomedical services, public holidays coming in between, uh, some of these ODNs do get cancelled and the dates may move. But it's important to maintain the lines of communication with the person who has PBC as well as the referrer and say, I'm sorry, our planned ODN has not gone ahead because of X, Y, and Z reason. It will take place on the next date. Do bear with us. So that line of communication should always be there. And some people don't always tell their patients that they're being referred to an ODN. And when they do have appointments with us, they don't know why they're here. So if
Yeah.
you are being referred to another hospital for whatever reason, please do ask your local consultant, why am I being referred? What are the concerns? Rather than just accepting that you've got an appointment to see someone new.
Okay, perfect. That's helpful. All right, thank you. Vitamin D,
Hmm.
vitamin K,
Hmm.
and also hypercalcemia.
Uh-huh.
Um, what can you tell us about vitamin D and PBC?
Mhm.
And what can you tell us about hypercalcemia in PBC, please?
Is it hyper or hypo? Sorry,
Hyper.
hypercalcemia. So most people with PBC will have that, well, should have, in my opinion, have their vitamin D levels checked at least once every few years, if not once a year. And that is because if you're low in vitamin D, which most people, where you are, Robert, will probably be low in vitamin D at this time of the year, because vitamin D is derived from sunlight, and as much as I love Scotland, there is not much vitamin D exposure that you will receive at this time of year. And similarly, most people with sort of my race and my extraction will also be low in vitamin D at this time of year, because people of darker skin process vitamin D very differently compared to people of fairer skin. It's important to recognize this for several reasons. Number one is, when you have PBC in its more advanced stages, you will metabolize and process vitamin D less efficiently, and there is a risk that vitamin D levels can be lower compared to people without PBC. You won't absorb it as effectively if you've got advanced liver disease. The second thing is, even if you have very early stage PBC that's well controlled, because we don't live in a country which has got sunshine, good levels of sunlight most time round, vitamin D levels will fall over winter months. And I tend to advise almost everybody above the age of 50 who I haven't yet, who's got low levels, to take supplements. And that's because it can make you feel fatigued when your vitamin D levels are low. And when we see people with fatigue, which can be quite debilitating in PBC, we always check vitamin D alongside a handful of other things, because those things will be very treatable in the event sort of that they're contributing to your fatigue. There is some evidence now to also suggest that if you're low in vitamin D, then things such as ursodeoxycholic acid and other therapies may be less effective. And if you're low in vitamin D, then some of your immune cells maybe leading to, or more hyperactive and causing more immune damage. So there are certain immunological what's the right word? I wouldn't say complications, but consequences if you have persistently low vitamin D levels. So always ask your doctor just to check your vitamin D when you are being seen at least once a year or once every 2 years. One thing just to mention around the hypercalcemia thing is that alkaline phosphatase, which is what we would consider the biochemical hallmark of PBC, it's mainly from the liver that we see it, liver and bile ducts. But alkaline phosphatase can also be released from bone, from small bowel, and in women who are with children, who are pregnant with child, then it can also be released from placenta. So if we find that alkaline phosphatase values are up, and another liver-related enzyme that goes hand in hand, for example, gamma GT is normal or low, we might start to ask the question, say, actually, is all of this alkaline phosphatase due to another reason? And we will
Yeah.
check vitamin D levels, and we check calcium levels. And if we find that the calcium is high and the alkaline phosphatase is high, but everything else is normal, we would start to explore whether it's the bones that are making this alkaline phosphatase. And we would start to do other tests to see why the bones might have a higher turnover of calcium, higher turnover of alkaline phosphatase. If you've got high calcium and you've got PBC, I suspect your alkaline phosphatase will be up because of a bone reason, and your physician, your liver physician, your gastroenterologist would be or should be exploring input from another specialty who deals with bone health.
Okay, perfect. Thank you. Now, we're not going to mention your ripped calf from last year at all. Okay, we're not going
My
there.
what? Sorry, my what? Sorry.
Your calf, your ripped calf.
Oh, my calf.
Yeah.
Yeah.
So we're not going to talk about that at all. However, there is a question about running,
Yeah.
because somebody's rather kindly agreed to or volunteered to do a half marathon in aid of the foundation, and for
Very
that we're
good.
grateful.
Very good.
However, when they finish their run, they often have the runs, so to speak.
Hmm.
Now, they've tried Imodium, and that doesn't seem to work. Is there anything else that's either stronger or different mechanism that would help?
That's a very good question. I haven't come across that before. I mean, so as a fellow runner, so it sort of who runs every morning,
Yeah.
I sort of it sort of it's important to be sure that, to the best of your ability, that you've gone to the toilet before you go for your run, because there's nothing sort of that's more unnerving that when you're in the middle of the run or towards the end of your run, you need to find the toilet. So, but if they have diarrhea after run, that is something to me I haven't heard of that before, but it would certainly warrant some level of investigation. Either, I mean, I'm just not making assumptions here, but either it might be due to other energy supplements they may be taking, for example, protein shakes or artificial supplements, which can lead to loose motions or increased bowel frequency. That's the first thing I would perhaps want to sort of exclude on a medical history.
Yeah.
The second thing is excluding things with PBC that can give loose motions at times of stress. I already talked about celiac disease, but thyroid disorders is another one. And if that is also excluded, and if the person is not, and if this is an ongoing problem and they don't have any evidence of gluten intolerance, they don't have any evidence of thyroid problems, they're not taking any protein supplements, then they would have to see a gastroenterologist for further investigation. It's certainly not something that's related to their PC, at least in my experience.
Okay, perfect. Thank you. I appreciate that. Okay. The other thing I was going to just to jump back, I didn't think of it at the time, but if you are the person who asked about the ODN, get in touch with us. So, because we might be able to know somebody who knows somebody just to double check any
Yeah,
of
yeah.
that
Yeah,
process.
and
So,
by all means, if it's my ODN, then let Robert know, and Robert will phone me and email me and tell me off. Because yeah, because it's very true, and I'd be lying if I said we have 100% efficiency where nobody's ODN decision has been delayed. I mean, that
yeah,
is unfortunately not true.
absolutely. No, I appreciate that. Thank you very much. Okay, so a couple of questions about Urso now.
Yeah.
So, somebody who's asking about shedding hair.
Hmm.
And again, I've heard over the years, that sometimes happens when people start Urso. We've also got somebody that's just started Urso. Now they're talking about awful back pain, which I've never heard of. They're also
Hmm.
talking about quote unquote frequent potty breaks.
Mm.
So do you want to say a couple of things about those, please?
No, sure. So, I mean, yes, we have, we have seen some, some people who report a little bit of hair loss with urso. Nobody understands the exact mechanism, uh, if I'm being very honest. What we see is that if your PBC was very active before you started urso, you start it and your bloods have improved, and then you've had hair loss. That is a common phenomenon in people who've been very sick at the start or had very advanced liver blood test elevations at the start. And that's because when you have an untreated or very active health disorder that suddenly comes under control, your body undergoes certain changes. What happens when you're ill during that phase, less essential parts of the body, according to what you sort of sort of the what the human thinks, such as hair, such as skin, they stop turning over at the same rate. So, for example, we see it in very ill people in hospital, no matter what they have. We see it in some people with PBC and other liver conditions. Before the treatment starts, their body is in a heightened state of inflammation. So less essential parts of the body, as I refer to your hair, your skin, your nails, even can they are not preserved to the same with the same right that they would in under normal circumstances. When they get better, then and normal regeneration restarts. And I mean, again, so just one more thing is some people, for example, their periods stop when they're really ill, and then they restart much later with a vengeance, and that's because that's not considered an essential thing for your body to preserve. But when you get better, then and your body starts to turn over in its normal way, skin, nails, hair, periods, then the parts that those are parts that were effective, you will start to notice certain changes. So because your hair is very noticeable, the hair has stopped growing when you're ill. But when you start to get better, the dead hairs that have stopped having their, so all their nutrition and blood supply, they will then be pushed out as brand new hairs are growing and poking those hairs out. In a similar vein, some people notice brittle nails or slightly abnormal changes to their nail color when they're ill. not when they're ill, sorry, in recovery from illness, that takes a long time to sort of get back to normal. Others notice sort of skin peeling and skin flaking. And I already talked about periods starting with a vengeance when people have gone from this state of not being treated to treatment being effective. And we see it even in people with celiac disease and other health conditions.
Yeah. Okay. Thank you. We've had a follow-up question. Is cirrhosis associated with hair loss?
Yeah, so absolutely. Akin to what I was mentioning a few minutes earlier, when somebody is really ill, and if that illness continues for long enough, then that will lead to your body saying, right, I'm going to direct all my attention to preserving more essential traits. For example, I need to be sure that the heart is pumping well, that the kidneys are perfused to the best ability, the gut is perfused, and less essential things such as hair, hair, skin. Those things are given, are almost treated like second-class citizens. And the other thing that we notice in people with cirrhosis is that they tend to lose muscle mass in
Yeah.
very advanced disease stages. And usually their arms and the thighs, they lose muscle mass and function, and people tend to feel a lot that they have a lot less energy. But that is a very advanced disease stage.
Okay. Thank you. Now, with regard to, so I'll be interested to know your experience because
Mm,
I guess this is one of the conversations that we have in patient support that would be different from the conversations that you have. I think because of the timing of appointments. So we often hear of people who just start URSO
mhm,
who tend to be slightly looser and have more potty breaks, but then that normalizes as their alk phos comes down.
mhm.
And I've
Yeah,
always thought about the mechanism of URSO and the fact that it's being given to flush the bile out your system, and
yeah.
the only mechanism that goes through is the bowel. So again, I just wanted to highlight that so that if patients are starting URSO and that is their experience, that's a common thing. And I don't know how much you've heard
Yeah.
of that because
Yeah, no, absolutely. So when we start ERSO, we always say it's safe, well tolerated by the vast majority. But anything that affects bile acid, metabolism, circulation, including ERSO, it can lead to digestive symptoms, be that an increased bowel frequency that is often short-lived, what we call dyspepsia or a little bit of heartburn, sort of going back to some of the early questions around reflux. And in rare circumstances, a bit of bloating. Often, that, as you alluded to, that passes after a few days to weeks. But that is common with anything that affects bile flow. Even in people who start statins, for example, they can get some people report some digestive symptoms because bile is made from cholesterol.
yeah,
And it's important to recognize that these are almost always short-lived, but if they do last for a week or two and they're not going away, speak to your consultant about an alternative preparation of urso, because some of the things that urso are packaged in, such as artificial sweeteners such as sorbitol that form capsules, some of the other additives that they might put in these pills, they can also be causing some digestive symptoms. And if the symptoms last more than a few days or weeks or are intolerant at any point, you can speak to your consultant and they can switch you from a capsule to a tablet that's dry or a tablet to a liquid. So there are various different preparations that you can take.
perfect. That's helpful. Thank you. Great question, which I've never encountered. So I'm learning so much today. So thank you. I'm so grateful you're here. Here's my next question. Alk Phos, bilirubin,
Oh, Robert, I
all
think you frozen.
normal.
I mean, you're frozen.
Oh, you still there, Palak? Okay, I'm moving.
Yeah, I'm
Palak,
still, yeah.
moving. All right, okay, perfect. So Alk Phos, normal. Bilirubin, normal. Gamma GT, still always high. Any thoughts? Anything you can offer?
So if the gamma GT is the isolated parameter that is elevated, I'm not overtly concerned that the PBC is active. We use gamma GT for a couple of reasons. Number one, in children, alkaline phosphatase is mainly from bone, so we don't tend to check it. We use gamma GT as a proxy, and that's another enzyme sort of made by the liver. When people are seen in the adult service where I work, we check gamma GT for a couple of reasons. Number one, we check it because well, first of all, we want to be sure that when we see high alkaline phosphatase values, it is predominantly liver related. And if it's not, and if the gamma GT is normal and the alkaline phosphatase is up in somebody with PBC, we would think of another source, as I alluded to earlier, that's not liver related. In this case, it's the reverse. It's the gamma GT being up and alkaline phosphatase values being normal and everything else being normal. Gamma GT is a very sensitive marker. It can fluctuate day to day by quite a lot. So if anybody drinks, say, a few too many pints of alcohol one evening, if somebody is overweight, or if somebody has had a big meal even, you can see slight elevations in gamma GT afterwards. It fluctuates a lot more. It is a lot more sensitive in adults to that to that degree. Now, we absolutely know that PBC has nothing to do with alcohol. It's not caused by alcohol in the slightest. But what we do tend to see in other conditions like alcohol-related liver disease is that in people who return to drinking, we see the gamma GT levels fluctuate high. I mentioned that in some people who've been to buffet restaurants and had big meals, the gamma GT levels can go up suddenly. So often, if we see an isolated elevated gamma GT and everything else is fine, we are not too worried. It's very likely that it's not that your liver is fine, but it may just be to other lifestyle factors.
Okay, perfect. Thank you. Now, question about chronic kidney disease, and I've lost it. I'm just going to try and find it again.
Sure.
Right, so this is actually somebody who was referred to the long COVID clinic, and the report said they've got stage 2 chronic kidney disease. Now, it doesn't say anything about if they're on fibrates or not, but their liver levels are normal, and that's taken a while for them to get there. So I guess they are just concerned. Is there anything they should ask, anything they should know?
Sure. I mean, there are certain kidney problems that are more common in people with PBC than the general population. It's conditions where your kidneys can't get rid of the acid that it needs to get rid of, and that can cause, and it's not the acid itself, but it's the kidney disorder, what we call renal tubular acidosis, which can cause kidney problems. So first of all, if you have PBC, and even if your liver tests are normal, it's important to ask that question: is this linked to my PBC? Is this a kidney problem linked to my PBC? If this person has very advanced liver disease, that can cause a different kidney problem, what we call hepatorenal syndrome. And it's unlikely in the context of in the context of normal liver biochemistry for that to be the case. But if you have fluid retention, such as around your legs or your abdomen, what we call ascites, that is also important to ask.
Yeah.
I suspect in this individual's case, if it's not going to be related to those two things, and I'm assuming it's not related to any medicines that they're taking for their PBC, such as fibrates, or it's not related to a painkiller or an antibiotic or something that they're taking for other health concerns, it may be that it's related to COVID. So in the very early COVID waves, where significant damage was more common than it is now, we would see kidney injury quite often in hospitalized individuals. So it's important to ask, is it related to the COVID? I think it's I know it's much less likely in current waves, but less likely does not mean impossible. So you can ask them saying, is this related to my COVID? And if this person was diagnosed with PBC before they got COVID, then the hospital that you're under would have your pre-COVID kidney function as well. So those are the things I would certainly ask.
Okay, perfect.
To.
Thank you. Okay, I want to be respectful of your time, so we'll try and see if we can go through a couple of questions in the quick fire round.
Sure.
Any thoughts on Ozempic for weight loss?
Yeah, so Ozempic for weight loss, it's very popular in America. We've run out of some of it in the UK now because a lot of people have been taking it. It is still a new compound to help with weight loss. I would say don't buy it over the counter. Don't take it of your own accord. We do see it being effective for weight loss and controlling diabetes because it was a diabetic drug originally, but it can cause some kidney problems, and it can cause things such as inflammation of the pancreas, inflammation of the gut. So don't take it unless you're advised to do so by a hospital physician. That's my advice.
Okay. Perfect. Thank you. So this is somebody who knows somebody who knows somebody, but they already have celiac disease. It's a male who's 18 years old,
Hmm.
just been diagnosed with PBC,
Hmm.
and the gastro wants to prescribe steroids. Is this standard practice?
Not for PBC, no. There may be other reasons why, but I would not give steroids for PBC
Okay, thank you.
or celiac disease. Yeah.
All right, perfect. Thank you. Is it common to have to have fluctuations in alk phos when on urso? Everything else is within normal range.
If it's just above normal, going to normal, just above normal to normal, that is common. If levels have come down but not normalized, that is expected. But we would normally give it a year before we determine if the fluctuations are anything to worry about.
Okay, perfect. Any link between PBC and low sodium?
Not unless the person has very advanced liver disease.
Okay, perfect. That's not to worry you. That's not to tell you that you have. It's just
Yeah.
okay, perfect. Thank you. And then the very, very last question. Somebody's asking about FibroScan. Can you explain just a little about it? When should you have one, etc., etc.?
Yeah, so FibroScan is like an ultrasound, but gives us a number of how stiff your liver is, rather than what it looks like. So it's an indicator or a proxy for a liver biopsy, telling us how scarred it is. It can also pick up things such as fat on the liver, what we call reflectivity of the liver. And we would normally do one once somebody is established. I do one once somebody's established on ERSO, usually 6 to 12 months into their course. I don't tend to do it just at diagnosis. And I tend to do it every couple of years afterwards to be sure that, as well as the liver blood's improving and staying stable, the fibrosis score on the FibroScan is also stable.
Perfect. Thank you very much. Dr. Palak Trivedi with a correct score of 47 with no passes. So, great session. And again, the thanks are coming up. They're coming up in the box. They're coming up on Facebook.
Great.
Fantastic. Thank you so, so much for joining us today.
Thank you for having me.
So I'd love to hear that we're going to be seeing you in April, but we will talk
Yeah.
about that another date.
Yeah.
But listen, thank you so, so much for coming in,
Cool.
for taking the questions, for taking them live, unprepared, just sitting there and just seeing what else comes in. So, so grateful. And the patients are as well, and it makes a huge impact for what they're trying to do and to live their best life with PBC. So for everything, thank you.
Thank you.
All right, it's been a pleasure. Right, guys, we're going to close off there. So thank you very much. I hope you've enjoyed that. I hope that's been helpful. We're going to stop the recording.